Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
So today we are going to hear Professor Arjan van der Loosdrecht from the Amsterdam University Medical Center, and he will talk to us about MRD measurements in MDS, but also a little bit in general in myeloid cancers. So Arjan, can we use flow for this, or how are we going to approach MRD measurements in MDS?
Thank you for this kind interview, Kirsten, and I'm happy to discuss with you what is actually meant by measurable residual disease. It was known as minimal residual disease, but actually it's about measurable. We can measure the signal, and we have to also to know what we are doing with that, in the sense of that measuring a signal of a disease after courses of chemotherapy or immunotherapy or whatever the therapy might be is a sum of intrinsic features of the disease itself, as well as resistance mechanisms due to whatever the drug might be, as well as the complex interaction with the microenvironment. So after, in general, measurable disease is a complex sum of all kinds of effects. And therefore, I think it is of interest that you have a kinetics of a disease under treatment, and at the end, the results. And the signal of those measurable residual disease is highly correlated with disease outcome. In MDS, we have some data, but the main data comes from the AML field. And actually, already some years ago, in the AML guidelines, it was recognized that we can define a classical complete remission for a myeloid disease, mainly AML. But on top of that, we can now also define complete remission after one or two or more courses of induction chemotherapy or other therapies, with or without the detection of measurable residual disease. I think that's important that in AML, it's already quite established, both retrospectively as well as in prospective clinical trials. So that's actually what it is.
And isn't it not more complicated in MDS to which cells you should actually be looking for, or which signals you should be looking for?
Yeah, that's a little bit dependent on what you use as a signal. If you think that the blasts by the microscope, or better defined by flow cytometry, for instance, the progenitor cells or even the leukemic stem cells. If you only focus on those very well defined cells, as leukemia initiating cells, for instance, then you can use the same principle. If you look better to MDS, it's really a stem cell disease. So that therefore I think measure to detect disease on the leukemic stem cell might make sense. But upon that, if you look to a lower risk MDS, for instance, there's a whole range of also dysplasia in the more maturing cells. So you dependent on what you think is most important, you can either go to the early leukemia initiating cell, name it stem cells or more progenitor cells, together with or without measuring dysplasia. And that is a fully different approach from AML towards MDS. And now we do not clearly know yet what is most important. I think measuring the leukemic stem cell burden, but maybe also in therapies concerning more modulatory effects, maybe also apart from aberrant cells on the leukemic stem cells, together with dyspoesis, which there's a different approach, maybe the sum of those can detect best the effect of therapy.
And can you maybe to this audience try to explain how you identify the leukemic stem cells? What are the necessary markers for this? And
actually, traditionally we look with several techniques. One is multi-parameter flow cytometry. That's one. And secondly, the molecular biology, molecular markers of disease. Now, within AML, we only have validated, for instance, NPM1 by quantitative PCR. That's a good marker and is now in the guidelines. We can measure quite good that measurements. Going to the flow approach, it's all validated with a specific sets defined by the European Leukemia Net, as well as /EHA platforms, which is now robust defined. And that concerns parameters within flow cytometry concerning the progenitor cell compartment, so the CD34 positive cell populations. And if we look to aberrancies, we look to a leukemia associated immune phenotype. That's a quite a long name. So we look to those aberrant antigen expressions on the level of the CD34 positive cells. Yeah, so the progenitor cells defined what we think are leukemia initiating cells. Yeah. And we look to aberrancies, that means those antigens expressed on leukemia initiating cells and not expressed on normal progenitor cells.
And how many markers would you need for that?
Yes, that can be discussed. We use in general a set of 7 or even more well-recognized, validated parameters. And among these are CD7, that is a lymphoid marker, but the lymphoid marker on a myeloid progenitor cell is aberrant. So that's a very strong one. And also the CD2 or CD5 are markers of lymphoid origin, normally not expressed on normal progenitor cells, but expressed on aberrant cells. Yeah. And there are some markers are more frequently found than others, and we should have a panel which can define most phenotypes which are most prevalent. Yeah. And sometimes we have, for instance, a whole population of cells which are aberrant by CD7 and a subpopulation with, for instance, CD2 or another marker. And then the leading phenotype is based on the most frequently existing CD34 positive cell. But that's quite easy, the lymphoid progenitor cells of lymphoid antigens.
And what about if you look at MDS? So will these aberrant stem cells not be different within, at least among the different subtypes of MDS, or also within a person? Is a leukemic stem cells always the same, or how does it work?
Yeah, the comparisons between AML and MDS per se are not yet there, really robust data. But I think that there are not so much differences at all between these entities, except from those antigens which are myeloid differentiation antigens, such as CD13, CD33, and then MDS comes in because if you look to maturing cells, the expression of normally myeloid differentiation antigens are fully aberrant, are dysregulated. So that means, for instance, that CD13, which is normally expressed intermediate on 34 positive cells, is expressed very high on the next stage of differentiation to pro-myelocytes, and is then rapidly downregulated. So if we look to focus on flow cytometry now, and we look to what is really aberrancies on the progenitor cell level, on the CD34 positive cells, to make it a little bit easier, is that we can look to antigens which are normally not expressed on myeloid cells, such as lymphoid markers, CD7 I mentioned, CD2, CD5. Yep. But we can also look to so-called asynchronous expression. That means that some differentiation antigens are highly dependent expressed on several differentiation stages.
Yeah.
So, and that is also a kind of an aberrancy. So an antigen which is normally not expressed, but is well of myeloid origin. So both the lack or the overexpression of those or asynchronous at a different differentiation path is all part of the so-called leukemia-associated immune phenotype.
And what I was thinking, you probably answered that, but within an individual person,
Yeah.
will this clone sort of be the same, or will there be more different? I mean, will it be heterogeneous? How does it come out?
Actually, within this compartment named CD34 positivity, we can find several labs, several leukemia-associated aberrant immune phenotypes. And what we now are doing in the standardized European leukemia platforms is that the most prevalent lab leukemia-associated phenotype is the phenotype we will follow. But it's not fully true, because you are several clones, maybe, which are aberrant. So what we now do is at the start, we have a time point 0 phenotype, and we define those phenotypes, the several phenotypes, and then we follow them during the treatments. And in early days,
right?
And they can change. So the shift in immunophenotypes, what's called the shifts, immunoshifts, come up or come down. Several phenotypes go away, which might be representative for a specific clone, and others come. And like molecular clone definition, so DMT3A or TET2 or others, can occur within a specific clone or are part of several clones. And what the research direction is going on, that we separate that by flow fax machines, so by separating several flaps and put them into a molecular analysis. And then look whether or not those clones really represent different molecular defined clones or not.
So is this research, or is this actually
That's research? That's research. That is research.
Because it sounds a bit complicated for
routine, well-validated platforms. Those platforms are available, but they focus mainly on the CD34 compartment yet. And no, there are also CD34 negative leukemias, and then we do have another approach, and we have the 117 as a marker, but not in a pro-myelocytic stage, but in the early stage. And in addition to that, but that is also then experimental, is going to a level deeper to the CD34 positive, CD38 negative population. And that is what we call now the stem cell compartment.
Yeah, the very early ones.
The very early. And that's of interest that upon classical MRD, the leukemia stem cell MRD, and you combine that both, then you have a more discriminative power in the prediction of relapse. So, and that is in line with what you was asking. Can we combine several technologies? So within the traditional flow, we can add now leukemia stem cell flow. And there's just a paper or several papers are already published on that subject, but not routinely used yet.
No.
But then you can ask, what can we do with, for instance, quantitative PCR MDA, like the NPM1?
The usual,
And that is well established. And if you combine those technologies together, they have an increase in predictive power.
So because what the hospital administrators always ask you, can you not take out one of these? I mean, it's expensive to do flow and NGS, but the answer is it's better to combine, right?
Yeah, at the end, and if you look to NGS, for instance, and excluding the TET2 and the chip-like backbone mutations, you have to rule out them. But also within the HOVON prospective studies, you may be aware of, but also from other studies from the UK, it was shown that putting upon the flow well-established platforms on next-generation sequencing, you can better discriminate patients with the predictive power of cumulative incidence of relapse.
That makes sense, of course.
But the main question is, Kirsten, is okay, if you know that, we have a predictor, but if you treat them differently, is the outcome also then better?
Yeah,
So
that's absolutely the most important question, right?
That's the most important question.
And also, if there is a treatment, because I think in MDS we are rather limited. I guess in AML there are more options, right? But
yeah, and if you translate it to AML first and then come to the MDS question more specific, if you look to some data, how you can guide MRD for clinical decision, how you can guide treatment decisions based on MRD, there are data that, especially in an intermediate risk group in AML, if you have a intermediate risk according to the European Leukemia risk classification, and you are MRD negative after 2 courses, you can then better go to an autologous stem cell transplantation, rather than an allogeneic transplantation, because then the outcome is much more better because you do not lose the patients of the toxicity of the transplant. But
this
vice
is
versa.
interesting to me because I think we hardly ever use autologous transplant in AML.
Yeah, that is.
But, a lot.
Yeah, it's a standard in the HOVON group,
Interesting.
and because we lose patients due to an allo transplant.
Yeah,
and if it is not
all the complications.
Better, yeah, right. But that is not true for the MDS. I think MDS is really another disease than AML.
No, MDS, I don't think you can find the problem in MDS is to find a healthy stem cell, isn't it? I mean, that's
yeah. What is it actually? But if you now go to the MDS setting, and we have the data now, and also from other groups which are a mixture of AML as well as MDS, and treated accordingly with high risk of high dose chemotherapy. And if we look to the data produced by the HOVON group, for instance, in general, we see that patients with high risk MDS versus AML, with the same induction scheme, with the same consolidation regimens, MDS will always work.
Yeah.
Always.
Yeah. We know.
But then it is interesting if you then separate those patients within the MDS, the high risk MDS by definition, and we separate those MDS patients with MRD positive after 2 cycles of classical induction chemotherapy, they do even worse than MRD positivity in the AML setting, what is expected.
Yeah.
But if you are MRD negative in MDS, you do as bad as the MRD positive in AML. So can you follow me? Normally, if you are MRD negative, in general, you do better. But if you are MRD negative and an MDS as a background disease, you do as bad as in AML, which are MRD positive. So although these data should be confirmed, and still we are busy with the analysis to get into more detail, it is fortunately it's linked to a molecular backbone, I think.
The molecular backbone of MDS is different, right?
Which dictates the outcome, I think.
But
that can already be measured by MRD status.
So isn't it a problem that, I mean, if in the ideal setting, when should you use this MRD measurements in MDS? Because with the number of options we have for treatment, and so how do you see this?
If you look to high risk MDS, for instance, for the first, then in general, high risk MDS, which will go to an allo transplant and with an excess of blast, have conventional induction chemotherapy in most countries. Then I think, as we do, and the data of other groups support, is that we use the classical induction and we follow the MRD status according to AML protocols.
Also before transplant, or after transplant?
Before going to a transplant. Even we have, although the prevalence is very low, you have MDS patients which are relatively good risk AML-like. And those patients are still going to an autologous transplant in HOVON study.
Wow.
And that is different from, and whether or not that is fully correct, the data see the same results. So I think in that context, we are doing well. But in general, the most patients are high risk. So I have a high European leukemia risk profile or a IPSS molecular risk profile, which is high. So they should go to a transplant, but does not per se exclude. If we go a little bit further with this MRD in MDS, and we go to a lower risk, the data are coming. And what we can see, for instance, if we look to dysplasia in MDS by flow, at the concept that you can objectify quite objective the aberrancies in the maturational profile of low-risk MDS. Yeah, and if you then look to, for instance, under treatment with lenalidomide, for instance, in the del(5q) or even in a non-del(5q), you can see that if patients respond to len, for instance, by hematological improvement, we in general see that also the amount of aberrancies on maturing cells is going to normal.
Then you see the aberrances in expression profiles? Or?
Yeah, right. So the dysplasia objectified by flow is normalized towards normal hematopoiesis, mainly in those patients who also do response with the current response criteria like hematological improvement or red blood cell transfusion independency.
Yeah.
So that means that there is a correlation of restoration of towards normal and the known improvement data.
Yeah.
If we can really use that in clinical practice, for instance,
that was my question.
To ask the question in patients who are not responsive to len, for instance. Yeah. However, they normalize dysplastic hematopoiesis. What is the outcome of those patients in terms of event-free of overall survival or duration of transfusion independency, for instance? That's only a little bit hypothesis-driven yet, so we don't know yet exactly. What we do know is the normalization of hematopoiesis in the EHA-treated patients group. So in the azacitidine, there are 2 papers published showing that patients under EHA, so high-risk MDS patients, which do not respond clinically at 6 months. However, the amount of aberrancies are significantly lower control to baseline. They have a better overall survival. And that's interesting because
should we continue? Should we not continue? That is
right. Exactly. So
do you think it can be guided by that? Because that would be
prospective data are not yet there. Only data suggesting that patients who are stable but do not really approve regarding transfusion dependency or other parameters, but do have normalization of the abnormal hematopoiesis, do better, and then you can decide, okay, we have no progression, this one. We are stable, but not better regarding transfusion dependency. However, the dysplastic features are better. Then we are allowed to continue EHA treatment longer.
I think that would be a very important message, actually, because this is always a challenge, when to stop them.
So that could have a direct effect on clinical decision making.
So
that's it. But the data are maturing, and actually you should have a randomized trial in which you have that stable patients, you stop, and the other group you continue, and then etc. Then that is the really final proof. But the concept is of interest.
It's very interesting.
But you can also say, why not by molecular markers? But the molecular markers are not so indicative to stop or not to stop for continuing EHA treatment.
I guess in most situations they are not, and which ones should we then pick, right? Because not the chip alterations, but I mean, even among the others, they seem to be going a little bit up and down,
Right.
So
there's a
what
lot of
about the transplant? Have you any experience with that? I mean, after measuring
actually,
MRD after transplant?
we do not have, we do measure after an allotransplant also MRD levels. Not in a clinical trial setting, but the use of MRD after transplant is of importance because you can taper earlier your immune suppression, for instance, or you can add upon on DLI in the absence of graft versus host, for instance. Now, however, prospective studies are not there, but you know that in the Scandinavian group, mainly Sweden, and you are part of that, they try to molecularly define the post-allotransplant setting.
Yeah.
And then also in the same concept, direct immune suppression or DLI or other immune modulatory strategies upon MRD assessments.
Yeah.
Yeah.
But I guess in that situation, would you then go for the molecular, the flow, or what would you
not
think?
Known.
Not known.
That is the difference between the molecular believers and the flow believers, I think. And at the end, you should combine it.
Yeah, I think you're right. Also, according to what you've shown earlier, I think that combination is like good.
In clinical practice, a lot of groups already use the chimerism as well as the MRD assessment post-allo to optimize their post-allo treatment strategies.
Yeah.
And I think that is true. That's in some extent clinical practice, but there are no randomized trials yet to make it really clear.
No. So that's
there are no randomized trials at all about allotransplants. So that
no, it's interesting how this is the most dangerous treatment in a way we have, and still
Still there are a lot of discussions about the best mode. Yes. So if I can summarize, if you may allow me, I think it is important to have the MRD on board of treatment decisions in the future. In the AML field, it is well established. And note the response criteria for MDS, high risk MDS, are just defined by the working group. But note, MRD is not in the response criteria in high risk MDS yet. So that is the next step. But on the other hand, I think that the translation from AML to high risk MDS is quite easy to go, but should be confirmed in the next years. In addition to the concept of MRD by measuring the CD34 positive cell compartment or the molecular stuff, upon that you can also think about the balance in restoration of dysplastic hematopoiesis.
Yeah.
What we discussed, and that is a new field, and it is not yet established. Can we really use a direct therapy based on normalization of dysplasia? And I give you some examples of in the EHA field, in the high risk, not going to a transplant plus on the HMA. Those data are quite convincing. And there are also in the low risk MDS under lenalidomide, there are upcoming new data which show that the hematologic improvement is at least correlated to the normalization of dysplastic hematopoiesis. But how to use that in clinical decision making is only hypothesis driven yet.
Yeah, but this would really, I think that is really an interesting way forward where I think it could make an impact on our clinical practice. I think that's...
Yes, as well, because the patients are older with low risk MDS, and thereby we have to carefully treat them regarding toxicities, and therefore you can make your decisions maybe earlier whether or not it makes sense or not to continue with at the end an inappropriate therapy at all. So that is the interest of the balance.
Thank you so much. I think we came around a lot of very interesting topics. So thank you very much for your time, Arjan. And I think we now know a little bit more about MRD and MDS.
It was my pleasure to have this conversation with you. Thank you.
Thank you also very much. Thank you.